Hi, good evening, everyone. Thank you for the kind invitation. So I heard some amazing presentations before me. So congratulations, everyone. Really deep knowledge in diabetic neuropathy. I will be presenting today the power of percutaneous tendon procedures in early intervention to treat diabetic foot ulcers. So the International Working Group on Diabetic Foot advised that we should look at the 5 elements. The first one, we should identify the foot at the risk, regularly inspecting and examining the foot at the risk, educating the patient, family, and the healthcare professionals that take care of the patient. One of the important things is ensuring routine wearing of appropriate footwear. And what I'm thinking is one of the most important is treating the risk factor that can develop ulcers. So there are a few options in offloading apical ulcers. So we can do digital tenotomies, distal plantar fascia release, simple tenotomies in isolation, or Achilles lengthening. So you can see in the image on the right, this gentleman has a plantar wound on the hallux. It's been ongoing for a while. It's been treated conservatively. However, the toe is slightly triggered. So we decided to do flexor tenotomy of the hallux, and you can see how it healed. I will show a few more cases. And tenotomies, usually we're looking at tendons, tenotomies, the flexor, the extensor, and the peroneus longus. The techniques available, you can do with a needle, percutaneous with a beaver blade, or you can open up and do it as a open procedure. So you can see in the images on the side that the top image is used with a beaver blade. We're looking for the tendon, exposing the tendon, and then with the beaver blade, you're just releasing the tendon. However, there is an easier option with a white needle, palpating for the tendon, then inserting the needle into the skin, finding the tendon, and just releasing it. However, all these cases of hammering of the toe or clawing of the toe, they should be assessed to be a flexible deformity. If it's a rigid deformity, you might not get a great result. So here you can see a video of a third toe tenotomy. You just literally find the tendon going from side to side with the needle, and you can easily feel when the tendon was released. And you can see how the toe is straightened. And you can see how I say straightened and not straight, because we're not looking to make it straight. We're just looking to do some offloading. As I mentioned before, hallux flexor tenotomies. So another gentleman with an ongoing wound on the apex of the hallux has been treated in the community by our colleagues with offloading, dressing. However, the wound wouldn't heal. So we decided we would do a flexor tenotomy. And you can see just 2 weeks after the release of the tendon, the patient healed. I just want to add as well that all these patients, they are vascular assessed, and we need to make sure they don't have any arterial disease. We can do also isolated lesser digit flexor tenotomy, so you can do just one toe if it's needed in early stages of the ulceration. You can see in the left side, the patient has a superficial wound, and it was referred to our unit to be assessed to see if the patient could have a tenotomy. After a few weeks, it healed really nicely. Also, you can do multiple toes in the same time because it's an easy procedure. And you can see this patient already had few amputations, and they developed a trigger hallux with a pressure point in the apex of the hallux. You can see that the second toe is clawing, and the pressure, it's on the apex as well. So we decided to do a hallux tenotomy and the second toe tenotomy. And you can see in the image on the right that the toes are straighter and they are wounds free. Scott and colleagues published a systematic review in 2016. They were looking at 42 articles, 5 eligible cases were included, and there were 250 tenotomies in 163 patients. And they found that the rate of success was from 92 to 100% healing rates in 2 months. They also found reoccurrence rate 0 to 18% at 22 months. They reported low complications, and some authors reported transferred ulcers on the other toes. This was a level 4 evidence for ulcer healing and prevention of reulceration. The question is, are we missing an opportunity to intervene early with the tenotomies? I think we should assess every patient in our podiatry clinics or our diabetology clinics or MDT clinics, and just make sure they are referred in a timely manner. Because, for example, if a patient has a claw toe or a hammer toe and you can see some callus on the apical, I think they will develop an ulcer, and I think they should be referred to one of our colleagues could release their tendon. It can be done on multiple toes, as I showed in some previous cases, as a prophylactic measure, so the patient might not have an ulcer or infection in the toe, so we can do it just prophylactically, so to avoid any ulceration. Also, we can do it in a combination with other surgical procedures. So in this case, you can see there, this patient already had the hallux amputation in the images, and the second toe started clawing, and they developed an apical wound. So we decided that we would release the second toe. I will present the case of a fascia release. This was a 50-year-old male with type 2 diabetes, diagnosed 10 years ago. He had peripheral neuropathy, retinopathy, hypertension, high cholesterol. He was obese. He had previous amputation of the left third and the fifth ray 7 years ago. He developed a wound and had osteomyelitis in the proximal interphalangeal joint, and on the left foot he had a a triggered hallux with a plantar distal recurrent ulceration. The pulses they were biphasic, and he previously had completed a course of flucloxacillin for 6 weeks and then continued with the 4 weeks of clindamycin. So what we planned for this gentleman was a right fifth excisional arthroplasty, was done in theater for the right foot, and you can see in 2 weeks it started healing, and the 4 weeks it was already fully healed. On the other foot, you can see at the moment we done nothing, but the right foot, it was intact, free of infection. We decided to intervene on his left foot because the second toe was clawed and hammered, and he developed pressure on the apex. We did a second distal interphalangeal capsulotomy and the flexor digitorium longus tenotomy. You can see the incision site, it was done with a white needle, it's minimal, and you can see how the toe was released. Also, we are thinking if there is a role of percutaneous tendon Achilles lengthening in offloading the acute Charcot, and we at the moment we're not doing this percutaneously. We only do it open. So this was a case of a 66-year-old male with diabetes for 10 years. He had ongoing ulceration of the first and fifth metatarsophalangeal joint. He had a cavoid foot type and a severe equinus. They exhausted all the conservative care. He tried bespoke orthosis. He had pressure studies. However, the wounds wouldn't heal. We did a procedure called tongue and groove lengthening under popliteal block and IV sedation. So you can see on the right side that the tendon was lengthened. And we're just suturing and closing back in layers, and we're making sure we get as much dorsiflexion we can. At the 2 weeks of pre-op, you can see this, the incision side is healing nicely, and the first metatarsophalangeal joint starts healing. And also you can see on the fifth metatarsophalangeal joint that the wound has healed fully. And at the 6 weeks post-op, the wounds are fully healed. However, on the first metatarsophalangeal joint, the skin is still fragile, so we would still offloading for a longer period. We checked for the ankle equinus. There was an improving the dorsiflexion. This is a flow chart done by one of my good friends from Lebanon, and he was really kind to share it with me. And you can see that there are different type of procedures. He thinks it would work better. So you can see in the middle area, there is a good point for the flexor tendon tenotomies. So I think it's a good flow chart to look when you're planning for the patients. We're also looking to look more into the tenotomies. We're looking to do an audit of our outcomes of minor amputation and our trust to identify complication rates. We're also looking to do a research in prophylactic tenotomies after amputations. Can we prevent further amputation? Also, we're looking to see the longevity of tendon releases and the percutaneous toe corrections. So in summary, think prevention is better than surgery. All of the surgeries carries a risk. Less can often be more. Intervene earlier before osteomyelitis or tissue loss. Provide functional outcomes. Increase minor procedure to prevent major surgery later. Offer appropriate care in timely manner with the right clinicians. We're thinking that as podiatrists, we can teach other colleagues in the department to be able to carry these simple tenotomies in clinics. Thank you.